Hi, everyone. Welcome back to another management VMR. Good morning, good afternoon, good evening. And thank you for joining us, whether it's near or far. We're very excited to discuss management of outpatient diabetes today. It's going to be another jam-packed session. And before I kind of go over what we're going to be doing today, I'm just want to say I'm like so ecstatic to co-teach and co-discuss with Reshma. I'm gonna turn it over to her for her to introduce herself to everyone.
Hi, everyone. I'm Reshma. I graduated med school last year and I'm doing research in California right now. And I've been working with Jazz for the past week, and it's been an exciting journey so far. And I'm really looking forward to share our discussions with you, and hope we all can learn something together today.
Perfect. I paid her good money to say that. That it was pleasure to work with me this past week. So I just want to say thanks to Bettina for doing teaching points today, and then Noah for being the scribe. Whenever you guys are ready, you can share the screen while I kind of go over. So today's VMR is going to
just a
be.
sec. I need to be a host.
Oh, sorry. I'll do that right now. Still new at this. I made everyone else co-host and I forgot you, Noah. I'm so sorry. So, there you go. You should be able to share it now. So today's VMR is going to have two cases. These cases are going to be breakout rooms. So I'll assign those breakout rooms in a second. There will be questions associated with those for those cases. And then when you return, we will discuss them as a group. I just want to point out there that this is a safe space. So if there's questions, if there's something that either something I'm teaching or something that Reshma is teaching that is not clear, please ask. This is a platform where we're all learning together. And even though, both myself and Reshma are like the discussants today, that doesn't mean we're the experts. So if there's something that you want to ask, or you learned something differently and you wanted to bring it up for a discussion, please do so. So with that being said, and then after the breakout rooms, we're going to be doing poll questions. So for those, we'll do those as a group as well. So trying to make it interactive, so it doesn't just seem like two people are just lecturing everyone. So if that interactiveness is good, please let us know. If you think it's too much and you prefer less things like that, then let us know as well. Before we begin, I just want to kind of ask, first of all, there's a lot of people on, so I just want to ask if there's anyone here today that is joining us for the first time. I see some familiar names as well, but some not so familiar names. All right. Well, if anyone's joining us for the first time and want to unmute and introduce themselves, feel free to. But if not, let's get started. Reshma, take it away.
Yeah. So before we get into the proper cases, can any one of you name 3 different ways or criteria we have for diagnosing someone with diabetes? Awesome. I think we got GTT, and yeah, I think we got all of it. So basically, it's fasting plasma glucose, GTT, and A1C. So fasting plasma glucose, like you all know, more than 126 milligrams per deciliter is like it's a diagnostic criteria for diabetes. And 2-hour plasma glucose values more than or equal to 200 milligram per deciliter during a 75-gram OGTT is a diagnostic criteria, and A1C values more than 6.5% is the third criteria. So yeah, shall we move on to the first case, Jess?
Yeah, and I just want to say that there's so many questions with diabetes, like for example, who to screen, when to screen, what are the A1C cutoffs and target rates. And I'm just going to throw in a quick plug to my friend and colleague Alex Smith, who's actually here today. Thanks for joining us, Alex. Along with David, who will be doing a diabetes management VMR next Saturday, who will be going over more details into that. So today we'll be focusing on outpatient management, and then hopefully not too far in the future, we'll be doing an inpatient management VMR with DKA and HHS. So as you will learn today, diabetes is so jam-packed with so many pearls, and we're going to kind of spread it out over few VMRs. But yes, let's start with reading off the first case.
Okay, so 49-year-old male with type 2 diabetes and tobacco use presents to the clinic for a follow-up appointment. Medications include metformin 2000 milligram extended release and simvastatin 40 milligrams. Vitals, his blood pressure is 150/95. BMI is 28. Labs, A1C 8.2%, total cholesterol 200, HDL 48, serum creatinine 1.2. Urine analysis is positive for is +1 for glucose and +2 for protein.
Perfect. And then I'm going to copy and paste the questions in the chat, but I'm also going to teleport it into the breakout rooms. I've assigned the breakout rooms already. So let's get started. You guys will have about 5 minutes and then we'll come back. All right. Looks like people are trickling back in. So hopefully that was enough time for you guys to go through the questions. Can someone in the chat just let me know that when I broadcasted the questions, because they wouldn't let me broadcast all three of them at the same time, did you guys get all three questions? Perfect. Awesome. Awesome. All right. So I'm going to unfortunately no. Okay, so one group did not. Navpreet, what questions did you not get?
So the thing was like we get into the break room so quickly that I was not able to go through the second and third question. So like I just
Okay.
remember the first question.
Okay, I got you. So you weren't able to go through all the questions, as that was
Yeah.
okay. All right. But you were able to see the messages?
No, there was no messages in our break room. For some reason, we were not able to see the screen as well.
Okay. All right. Sorry about that. All right, so let's go them as a group then. Let's try to go through this with groups. So the first question was, given this patient's comorbidities, what would be the next best medication to treat his type 2 diabetes? And I'll go with room 1. So that's with Bettina, Aisha, Noah, not Noah, but Abby and Arayu. Is there anyone from that group that wants to talk about that one? The first question.
I can go if Bettina's not able to talk. Oh, Bettina, you can go
Yeah,
ahead.
fixing the teaching points. No problem. So for our the first question is the one that we really focused on with our discussion, and we were thinking about adding an SGLT2 inhibitor for our patient. First of all, because the patient has hypertension. Secondly, we think there might be hints of proteinuria that we would want to check further with the creatinine ratio, which is more of the more specific test, I guess, for diabetic nephropathy. But in the event that the patient does test positive for that, an SGLT2 inhibitor would also be great for him. So yeah.
Excellent. Is there a group in here that did not pick SGLT2 inhibitor but picked something else? Okay. So the answer was SGLT2 inhibitors.
think
But I just
now-
want okay,
Oh,
go
sorry.
on.
I think now Preet has his hand up. Yeah.
Yeah,
Oh,
so
yes.
when we were discussing about this thing, because patient is having proteinuria 2 plus, so we were
Yeah.
kind of like reluctant to put the patient on SGLT2 inhibitors, and we were leaning more toward the GLP-1 inhibitors. So what are your thoughts on it?
Yeah, so before I answer that question, what were you all reluctant about specifically?
Like we were like trying to see because patient is having kidney damage because of the proteinuria in the urine, so we were like thinking of like not like thinking of something like to decrease the dose of metformin, and along with that put some other anti-diabetic medication like GLP-1 inhibitors. That was the discussion we were having in our group.
Yeah, so that is I'm so glad you said that. So and I'm glad, so that's why I asked if there was a group that did not pick SGLT2 inhibitors, because the answers here are guideline based, but clinical medicine is not clear cut. It's more of an art than it is a science. So what I mean by that is you have to deal with insurance coverage, you have to deal with, patient preferences and all sorts of other factors. So in this case, proteinuria, it's more effective. It's the medication SGLT2 inhibitors are more for proteinuria. So do a GLP-1 agonist have renal protection? Yes, they do. However, there hasn't been that many studies yet. They're on their way. There haven't been that many studies yet that says GLP-1 agonists are just as good as SGLT2 inhibitors for kidney protection. So you're not wrong with saying, I'm going to start this patient with GLP-1 agonist, because there have been some studies that have been shown that it has some renal protection. But for example, for the DAPA CKD trial, the Canvas trial, there's so many other big randomized controlled trials that have been done with the SGLT2 inhibitors that have been said, these are slam dunk medications that will protect your kidneys. So that's why the SGLT2 inhibitors are slightly better answer in this case over the GLP-1 agonist. That was an excellent point, Natalie. Now, what other comorbidities would you want to treat, and how would you want to treat them? And I'm going to give this to group 3. This is with Yuting, Kiara, Hans, Carmel, and Hamadad. Is there anyone there that would like to share their answer?
Yes, yes. In the group, we were talking about also the comorbidity that the patient had is hypertension. So we would like to target that as well. Maybe we can use an ACE inhibitor in that case to target, and yes, that's another of the pharmacologic approach that we talk about.
Correct. Was there anything other comorbidities that your group talked about treating or modifying?
Yes, his BMI was
Okay.
kind of high. So we're thinking of, for us, we're thinking of adding DPP4.
DPP4 or GLP-1?
GLP-1, sorry.
Okay. Yeah. No, don't be sorry. Yeah, that's a great thought as well. The BMI is a little bit on the higher end. Any other groups that had different or similar answers to group 3? Okay, so the answer for this one is actually ACE or ACE or ARB. I actually just go straight to ARBs now. The reasoning behind that is I've had patients start on ACE inhibitors, they get a cough, and then they're like frustrated, like, oh, I'm getting this cough, and so then they get a little bit more frustrated, or not frustrated, but a little bit antsy about starting new medication. So I just go straight to an ARB. They're just as good. And it's for renal protection, and it's for patients that will lower their blood pressure, will also help with proteinuria here. So the other thing I wanted to share, though, was the hyperlipidemia. So this patient's on a simvastatin. Simvastatin is a moderate intensity statin. You want this patient who is a diabetic who has uncontrolled A1C to be in high intensity statin. Exactly, Elena. Atorvastatin or rosuvastatin would be the more ideal choice in this patient. Hans, that's a great point with the ezetimibe. I think that's a great choice if the patient can't tolerate, or in an adjunct, if let's say even with a high intensity statin, their cholesterol is not getting controlled. I want to make a quick pearl about SGLT2 inhibitors. So when it comes to hypertensive effects, there's been studies that have shown that SGLT2 inhibitors have basically the same antihypertensive profile as a thiazide, about 8 to 10 millimeter mercury drop in blood pressure when you start is SGLT2 inhibitor. So basically, what I've been telling my patients is measure your blood pressure at home, hold your thiazide for a few days while we're titrating the SGLT2 inhibitor, and then if your blood pressure is good, you can slowly start adding back your thiazide. So in this patient, ideally, you would start the SGLT2 inhibitor, bring them back, and then if their blood pressure tolerates it, maybe add 5 milligrams of an ACE inhibitor or like a low dose ARB and slowly titrate that. So you don't drop their blood pressure too fast with an SGLT inhibitor and then an ARB for renal protection. Now, one can argue, you're getting that renal protection for SGLT inhibitors. Do this patient really need an ARB? That's a great question. And the answer is, there's still studies that say that a patient should be an ARB or ACE. They do have more of a RAS inhibition effect, where, remember, SGLT inhibitors will help with renal protection in another mechanism, but will not have a profound impact on the RAS inhibition. So remember, RAS inhibition is a huge factor when it comes to progression of CKD. So rather than picking another group, I'm going to ask the audience, what did you guys all put for the non-pharmacological intervention that would have been the greatest reduction on his ASVD risk score? Yeah, you guys all, Kiara, that's a really good one. Weight loss would definitely have a huge impact. He may not even need medications anymore. He can just be diet controlled diabetic if his weight loss, if he has some weight loss. But with the ASVD risk calculation in MedCalc, actually, I'm actually going to share my screen here. Can you guys all see my screen here? Okay, so this is MD Calc. You can easily Google this. And I basically put in numbers for a similar patient. So I show this to my patients because I hope you guys take away from this is this is a management reasoning VMR, and I hope you guys can use this with your patients. I pull this up with my patients and I show them this, and I say, okay, look, this is your age. You have diabetes. You're a male in this situation. Let's say if you were not a smoker, this is your cholesterol, this is your HDL, this is your hypertension, this is like your systolic blood pressure, and you're on treatment for hypertension. For this person, their ASVD risk score is 34.3. So they definitely need a high intensity statin. But look, if you're a smoker, 44.7%. And then I've had patients that come to me and say, oh my God, I know smoking was bad, but I didn't know it was that bad. So visual aid, provide a visual aid for your patients. It makes a huge difference. So the answer, it is like, I've had patients open up their eyes and say, wow, I did not really anticipate that much of a dramatic increase. So smoking cessation was the correct answer. So before we move on to case number 2, any questions or clarifications that we could provide?
Yeah, I actually have a question. I'm Masa, by the way. I don't think we've met. This is like my 4th or 5th session. Would you decrease the dose of metformin because of the proteinuria?
Yeah, that's a great question. And by the way, nice to meet you. I've definitely seen you on VMR, but we haven't interacted. So yeah, nice to finally talk to you. So I would not. Just because the
Okay.
proteinuria has nothing to do with it. Metformin, I think we overblow the whole lactic acidosis side effect from it. It's really rare. It's only when there you go, Alex said it. If it's when the GFR starts to drop, that's when I would, proteinuria has nothing to do with it. Creatinine doesn't have anything to do with it, because remember, creatinine is not that reliable. And I would look at GFR, I would look at actual kidney function.
Okay, thank you.
You're welcome. And then, Rishma, there was something you were going to ask the audience.
Yeah. So if this patient did not have hypertension, but everything else was the same, would you still prescribe ACE inhibitors even without the hypertension? So you can just like put in the chat and just say why or why not.
Exactly. Seamus said it. It's
Awesome.
Can you protect it? So there will be times where patients will come into the office. They don't have high blood pressure, but they just got diagnosed with diabetes. You still start, and they have evidence of proteinuria with no hypertension. You can start them on ACE or ARB.
Yeah, ACE or ARB is started as in a patient with type 2 diabetes if they have either proteinuria or hypertension or both. So just wanted to share that. If everyone is ready, we can move on to the next case.
Perfect.
Awesome. Case 2, a 45-year-old female with a history of SLE, end-stage renal disease on hemodialysis, hypertension, and hyperlipidemia presents to the clinic to establish care with a new primary care physician. She takes prednisone 20 milligrams, erythropoietin with hemodialysis sessions, amlodipine, and atorvastatin. On examination, BMI is 22, blood pressure is 115/74, labs, fasting blood glucose 160, and HbA1c is 5.6%.
Awesome. So the first question, I'm going to say it, and then I'm also going to post it in the groups, is does this patient have diabetes? Likely, not likely, not sure. And then the other question that is if you think they do have diabetes, what would you do? What medication would you recommend in this particular patient? And I will post that in the broadcast message. You guys will have another 5 minutes. All right, people are trickling back in. Welcome back. And let's get our screen shared. Thanks, Noah. All right, so I'm going to combine the questions just for the sake of time. And I'm going to pick a group that I did not pick last time. So let's go with group 4. So that's Messiah, Navpreet, and I think Shema, but Seamus can't unmute. So do you feel that this patient has diabetes? And if you think they do, what medication would you recommend in this patient?
Oh, Masha, you gonna go for it?
Okay, so I'm not sure if this patient has diabetes, but I think since EPO can affect HbA1c, then maybe we could check fructosamine.
Wow. Yeah. It's like you read my notes. That was amazing. Yeah, that was my teaching point. Well, I'll get to fructosamine in a second though, but you you commented on something that was one of the take home was the fact that there's something that that like when A1Cs are not reliable. So this patient, so I'm glad that you put I'm not sure, and that's the right answer. Is like we're not sure until we do like a repeat fasting, right? So or like do another thing like fructosamine. So I think this is a great segue of talking about what factors can really falsely elevate or falsely lower the A1C. So And sometimes this is a hard thing to just keep your mind wrapped around. So how I like to view things is, remember, what is an A1C? An A1C is glycosylated hemoglobin, right? That's when the sugar binds to the red blood cells and it sticks onto it. So then if it's stuck onto it, how long does that stay? About 90 days, because that's the lifespan of the red blood cells. So that's why normally, if the earliest you can check your A1C is 3 months, because if you check it every month, it's not going to change too much because there's still some red blood cells that are floating around. Now, what factors lead to changes in A1C? Well, anything that will either prolong the lifespan of a red blood cell. Okay, so that means there's more glycosylated hemoglobin because there's more time for that glucose to attach or bind to that red blood cell. And the other ones is something that will reduce the time needed for the glucose to bind. So what are those situations? Shema put it in there beautifully. So basically, iron deficiency anemia falsely elevates it. I'm going to just pick that as an example. Why? If you are iron deficient, your bone marrow is not getting the nutrients it needs to make more red blood cells. So therefore, I'm sure there's some mechanism behind it, but the bone marrow probably sends out a signal that says for the red blood cells that are like floating around, stay longer, live longer. So if they're really struggling it out, and if they're more than 90 days, there's going to be more glycosylated hemoglobin. So falsely elevates. Now, falsely low is basically when, your hemolysis is a great example because all those red blood cells are getting shredded. So some of the glycosylated red blood cells are getting shredded. Therefore, you're going to get a falsely lower A1C. Another great example of that is splenomegaly, or so basically it's going to engulf all those red blood cells. Whereas in prolonged is asplenia, whether functional asplenia or you don't have a spleen, because remember the spleen takes up all any used or red blood cells that are kind of deteriorating it as well. So that's the take-home point, is that A1Cs can be fluctuated for different reasons. Very quickly, what is fructosamine? So fructosamine is not perfect, but it's a great situation, and this is a great situation to use fructosamine when there's a discrepancy between fasting BG and your A1C. Fructosamine measures it measures glycosylated albumin, and albumin has a lifespan of about 2 weeks. So if you do get a fructosamine, it's roughly a prediction of your glucose control for the last 2 weeks, which could be good, because if you want to see how they did in the last 2 weeks, it's a better marker for that. But it's not perfect either. If you have nephrotic syndrome, if you have cirrhosis, if you have malnutrition, if you have protein-losing enteropathy, it's not a reliable marker there. So it has limitations, but in this situation, it is great for kind of getting a secondary test. So in this patient situation, you would not use metformin. And the reasoning behind that is the GFR. The GFR is less than 30. This is contraindicated. You don't want to use that. There's not enough data out there to really recommend GLP-1 agonists and SGLT inhibitors. There probably will be studies out there that can probably say that they are safe. But right now, SGLT inhibitors specifically, they work with a kidney that has a functional GFR. So right now, there's no evidence on that, and they're not recommended. So in this patient, you would actually use insulin because they're already on they're on dialysis. Anything I can clarify, or any questions?
Yeah, it's one question that came up in our group is if there's a preference for repeating in this patient for making the final diagnosis of diabetes, since we need to have a confirmatory test, whether the best confirmatory test would be to repeat I think the conclusion our group came to was that we probably first would repeat that fasting blood glucose, but whether to do that versus, like you mentioned, the fructosamine or pursuing an oral glucose tolerance test, if there's a kind of a preference among those tests.
Yeah. That's your VMR next year. No. So yeah, that's a great point. So I think that's basically preference. I personally, the best way to do it is just get a fasting BG, but I would not get a point of care BG because there's a lot of you can get like if they don't apparently when the MAs do it, they the medical assistants when they squeeze out the blood, if they squeeze it out too much or not enough, they can factor in the A1C level. But the main thing is I would just get another fasting BG, and if it's high, I get it. Then if it's high, then I want to know what was their glycemic control over the last 2 weeks, and then I would get the fructosamine. Now, when it comes to glucose tolerance test, it sounds like a fun test. You like drinking a sugary beverage, it tastes bad. It's not the most fun test, and a lot of patients, the compliance on getting it done is low. So in my experience, how I know that is when you do prenatal visits, a glucose tolerance test is something that we always do in pregnancy. So we have to like literally beg our patients to like please do get it done. It is not a fun test, and if you can avoid it without like and still get the diagnostic value, that is preferred. And this is where the art of medicine comes in, because preference. If some patients like, hey, I love drinking that syrupy thing, even though it tastes like maltose, but some don't like it. So does that help clarify that, Alex? Okay. All right, so I'm going to turn it over to Reshma for her talk on management of type 2 diabetes and CKD.
Yeah, sure. Yeah, so I am gonna briefly go over the management of type 2 diabetes specifically in chronic kidney disease. So the first point that I would like to stress on is that if the patient is on insulin, we don't have to make any adjustment to the insulin as long as the GFR is more than 50. So when the GFR starts to drop below 50, if the GFR is 10 to 50, we reduce the dose of insulin to 75% of the usual dose that the patient's getting. And if the GFR falls below 10, we reduce it to 50% of the usual dose. And so this dosage calculation is like the starting dose, and then we can titrate it according to the needs of the patient. So moving on to the specific stages of kidney disease and their management. So I'm classifying it to be initial stages, which is stage 1 to 3, and then stage 4 and stage 5, and the patient's on dialysis. So the initial stages, just like we talked about earlier, the best drug is SGLT2 inhibitors. But just like Jas explained, for SGLT2 inhibitors, we need to have a functioning kidney. So SGLT2 inhibitors prevent the progress of kidney disease, but they do not significantly reduce the hyperglycemia. So in that case, a GLP-1 agonist could be used as an alternative or an add-on. So these are the two drugs that are exclusively used for the stages 1 to 3 of chronic kidney disease. But there's one other drug called repaglinide, which is a meglutinide, but it has minimal renal excretion. Its excretion is mostly hepatic. So it has a sulfonylurea-like action, but it's short-acting. So this is another drug that can be used in the earlier stages of kidney disease. So for stage 4, which is GFR anywhere less than 30, but more than 15, what medication do you think is like most likely recommended? So yeah, SGLT2 inhibitors are great for stages 1 to 3. That's amazing. Just that when for stage 4, the GFR drops to below 30, SGLT2 inhibitors need more of functioning nephrons to act on, because the mechanism of action is to increase the renal excretion of glucose. So when it comes to stage 4, GLP-1 agonists are preferred over SGLT2 inhibitors. And in GLP-1 agonists, it's also important to take a look, constantly monitor for any GI side effects that they have, because the patient could easily go in for dehydration, which could in turn cause an acute kidney injury. For stage 5, which is GFR less than 15, what do you think? And the patient is not on dialysis. What do you think could be used? Awesome. Insulin is amazing. But since the patient is still not on dialysis, we could actually try some of the sulfonylureas that are metabolized and excreted by the liver and have a lower risk of hypoglycemia compared to the others. For example, like we have 3 sulfonylureas: glipizide, glimepiride, and gliclazide. Gliclazide is not available in the US, I believe, but glimepiride would be slightly preferred over glipizide for managing stage 5 when the patient's still on patient's still not on dialysis. And yeah, repaglinide, again, just like we talked, I think it's a great drug, but I think it's not preferred in the later stages, as in 4 and 5, because it has some component of renal excretion that could not, that would actually not make the drug likely for the later stages. And if the patient is on dialysis, just like the patient we have here, it's going to be insulin would be the best choice. Yes, so yeah, that concludes my discussion. And maybe we can go in for the poll questions, Jess?
Yeah, that sounds great. Just wanted to add a couple of points. I think repaglinide would be a good choice, but I think when it comes, so in terms of the sulfonylureas, they're good for CKD, especially when like CKD5, like Reshma mentioned, is the fact that like they're cheap. So insurance is not going to be a caveat. They're medications that I like to avoid unless I have to, and the reasoning behind that is because of the hypoglycemia that can present with it. And remember, patients can overdose intentionally or unintentionally on these medications, and it's a very scary experience for the patient. But only it's not a class effect. For example, glyburide you would not use in CKD, but the ones that Reshma mentioned could. And I just looked it up. Repaglinide, it would be a good choice in patients who have a GFR up to around like 14 to 20. So that would be a good choice as well. So let's do the polls. Really want to hammer on some of the pharmacology, and this is the last section that we have. So I know, thank you for everyone that has hung on for an hour here. So can you all see the question? Oh, I'm sorry, Elena. Peripheral artery disease. For those who are watching at home, this is a question of 55-year-old female with type 2 diabetes on metformin with peripheral vascular disease status post-amputation. She has an A1C of 7.1%. How would one manage this patient's diabetes therapy? Adding an SGLT2 inhibitor, GLP-1 agonist, insulin, or DPP-4 inhibitor? So we have 10 people voting for an SGLT2 inhibitor. I encourage someone to go rogue and pick the one that's not going with the popular one. Anyone wants to go rogue? Noah, your rogueness paid off on Friday. The only person that guessed sweet syndrome. All right, let's end the poll. We got a good amount of people. We got one person for insulin. All right. So basically, all of you put SGLT2 inhibitor. The actual answer was GLP-1 agonist, and I'll explain why. So candesartan is the only one that's actually been affiliated with amputations, but talk to any endocrinologist. If you tell them the patient has a history of amputation, they will pick any other medication until SGLT2 inhibitors are the only ones remaining. So because of that history of SGLT2 inhibitors leading to amputations or like a slight risk with SGLT2 inhibitors, and like it's very low. And like I think there was a Curbsiders episode that kind of like said that, this risk is like debatable even, but the thing is, board questions is not debatable. So when it comes to those kind of things, this question's take-home point was, if you have that history, let's just, even if there's a minor association, for example, if this patient had a history of necrotizing fasciitis, you probably would also stay away from SGLT inhibitors because you don't want them to have Fournier's gangrene. So there's something about that prior history that this patient's pathophysiology that may predispose them for something. That way you want to just avoid that. So that was the take home here. All right. Any questions on that? Okay, great. Gonna go back. I'm gonna launch poll number 2. So for those watching at home, darling, the answer was GLP-1 agonist. So B. Yep. So for those who are watching at home, 50-year-old male with type 2 diabetes on metformin, CKD, and recently lost his job and insurance. His A1C is 8.5. How would one manage this patient's diabetes therapy? Would you add insulin? Would you add a GLP-1 agonist? Would you add glyburide? Would you add an SGLT2 inhibitor? And would you add glipizide, or would you add glipizide? Man, you're really loving those SGLT2 inhibitors. Okay, now we got some variants going. Oh, wow. It's like I wish you guys, because I don't know can you guys see the results? You guys can't, right? Okay. I wish you guys can see it. It looks evenly spread this time. Noah, thank you for bringing that up. Unfortunately, in the United States, for the last few years, insulin is not the cheapest. Like, I'm glad it is in other countries. It's a great medication. All right, seems like a good number of you have voted. So let's end the poll. I'm going to share the results so you guys can see it too. So basically an even spread with a very slight preference for the glipizide, and that was the correct answer. And let's go through of why that was. So I added this question in, and because when we are treating patients, we want to live in an ideal world. Unfortunately, we don't, right? So there's a lot of factors that go into it. So this was actually a real case. This was actually one of my patients. He actually had a rough year. This was actually right when in the middle of pandemic. He didn't have like, I guess, the bandwidth / IQ to learn insulin properly, safely. So insulin was not the right choice. GLP-1 agonists, SGLT inhibitors, they're the new kids on the block. They're fantastic medications. They do so much good for so many different reasons. Unfortunately, though, if the insurance company doesn't cover it, or even with coverage, it is very expensive. For this patient, I sent a GLP-1 agonist and SGLT inhibitor to his pharmacy just for a price check. It was about $800 for an SGLT inhibitor per month and $1,200 for the GLP-1 agonist per month. So not realistic options. So then it comes to glyburide and glipizide. They're both sulfonylurea. So how do you decide? So the next thing you look at is CKD3. So he will have decreased clearance of certain medications. Glyburide is metabolized and cleared through the kidney, whereas glipizide is a sulfonylurea that goes through the liver. And Reshma pointed that out earlier in her case. So in this case, it would be glipizide. because even though it can cause hypoglycemia at a high dose, if you start it low enough, it'll bring his A1C down, and it's something that will be affordable. Any questions about that? So yeah, Shema, it would, yeah. So exactly, not all sulfonylureas are created equal. So glyburide, definitely a no-no for this patient. Glipizide, you can get away with it at lower doses. Yes. Yeah. All right. Last question. So for those watching at home, a 72-year-old male with type 2 diabetes on metformin, prior history of DKA, HFrEF, so that means heart failure with reduced ejection fraction, and most recent A1C of 8.6%. How would one manage this patient's diabetes therapy? Adding a GLP-1 agonist, SGLT2 inhibitor, insulin, or adding a pioglitazone? Shema, are you getting paid by an SGLT inhibitor pharmacist rep? All right, we got some more votes in here. Okay, looks like we're gonna have some learning. Hopefully, if I do my job properly. All right, so those are the results. There you go, Noah. Noah's on a hot streak this week, just slamming things out of the park with sweet syndrome and just everything. So there you go. So Noah, do you want to unmute and say, I think you're all tired of my voice. Noah's voice is very soothing and calming. If you can you unmute and talk about that?
Yeah, sure. So I was primed for this question because of the first poll, right? We were talking about contraindications for specific drugs. And one thing that stands out in this patient's history is the history of DKA. SGLT2 inhibitors can cause a condition that's called euglycemic DKA. So although the blood glucose levels are normal, the patient has DKA physiology. And I thought, well, this should be a contraindication.
Noah, GPT lives, the legend of that lives on. Yes, you nailed it on the head. So euglysemic DKA, I've seen it a handful of times. It's very scary. It's actually kind of crazy. The BG would be like 220, and their ketones in the urine is high. Their beta hydroxybutyrate is high, and you're like, and they look sick. And it's like, what's going on? And then you look at their med history and you see SGLT2 inhibitor. So beware of this. You will see it. It's actually not that uncommon. I've seen it 5 times in a span of 3.5 years. So it's scary. And so because of this, association, you just don't want to put that patient into another DKA. So in this situation, I would actually have gone with, I forgot the question option. Question number 3. I would actually go one with GLP-1 agonists. So things with GLP-1 agonists, we know, just how we know with SGLT2 inhibitors are great for renal protection. If you have a patient with a prior MI or a reduced ejection fraction, put them on a GLP-1 agonist. They are really good at cardioprotection. And now we're getting data that they're good at renal protection as well, but more studies to follow. But when it comes to their cardioprotection, it's really good. Now, we know that SGLT2 inhibitors have reduced the number of heart failure admissions. So, and the exacerbations, but GLP-1 agonist provides that cardio protection so that they don't have another MI and their blood sugar levels are controlled. So before I turn it over for Bettina for teaching points, I just want to make some concluding pearls and some concluding remarks. Why didn't I talk about metformin and like about first line? So if you look at the ADA guidelines, they will mention that metformin is no longer first line anymore. It's up to the clinician's discretion. Why didn't I say that? I'll tell you why. SGLT2 inhibitors and GLP-1 agonists, They're the new kids in the block. They're fantastic drugs. They really hammer home one concrete point. That is, we don't treat numbers, we treat the pathophysiology. And these medications have proven that. Because if you look at SGLT2 inhibitors and GLP-1 agonists, they only drop the A1C by 1 to 2% max. But they have so many good things that they provide. Unfortunately, we live in a healthcare system that is not easily accessible for these medications. So that's why I go back to metformin. I personally don't think I don't think we should jump to other medications. And a lot of endocrinologists feel that way too. Metformin is not a bad medication. It's cheap. It's, for the most part, tolerable. You will have some diarrhea, some nausea, an issue when you start titrating it. And studies have shown that metformin basically provides excellent cardioprotective benefits. So it's not a bad drug. And I think metformin is kind of forgotten in the background. It's like that, unpopular kid that no one pays attention to, but secretly is a genius, where they're all focused on the cool kids. So which is the SGLT2 inhibitors and GLP-1 agonists. So basically what I'm trying to say is, don't forget about metformin here. It's still, with the public, the public that we treat, is still the most sensible medication with great effects too. Last pearl, when you have a patient that comes into your door that's a diabetic, newly diagnosed diabetic, you have 5 years to bring their A1C into a good range, because after 5 years, the macrovascular and microvascular effects are going to be more profound. So if you can get their A1C controlled within 5 years, that patient reaps the benefits far more than after 5 years. Oh, all right. So for sake of time, Bettina, how about you pick like your favorite pearls? Because she had to make 2 blocks of pearls. I didn't know there was that many pearls. But actually, hold on, Bettina. I just want to give the audience a chance. Any questions? Okay. Just wanted to make sure that we didn't forget anyone, if there's any questions or clarifications. All right. Sorry, Bettina. The floor is all yours.
No problem. I think it's going to be hard to choose just a couple of pearls because there are so many learnings today and I really enjoyed every learning. So, but okay, maybe if I could choose one pearl that can summarize the whole thing, is that when we're choosing therapeutic interventions for type 2 diabetes, we look at the patient as a whole. It's not just about the glycemic control, but also looking at the patient's comorbidities, not just if the patient has CKD, but even what stage of CKD they're in. And the therapeutic intervention would differ per stage. And then also looking into what is their history. Do they have history of DKA? Do they have history of PAD? Which would be important indications or contraindications to choose which drug to give the patient. And at the same time, we also look not just at the medical side, but also the financial side of the patient, the social aspect of it, like what can the patient afford, especially with their insurance, or if they don't have insurance right now. And also understanding which drugs would be more affordable to our patients is important, because there are so many drugs in diabetes today. A lot of them are good still, even if there are a lot of new drugs that might be better and they might want it more, but we have to weigh the risks and benefits and the context of our patients. So that's my main teaching point that I wanted to share.
Love it. Concise and to the point. Thank you so much. All right. Well, Noah, I made your job a little bit light, but thank you so much for your scribing, Bettina, for your teaching points, and everyone for your attention. I hope you all have an amazing rest of your weekend.